Okay, good evening, everyone. It's a pleasure to be with you today. And we're going to talk a little bit about fibroids. I'm going to do kind of a general overview and kind of touch on some really important things to think about when patients present with fibroids or heavy bleeding. We'll talk a little bit about some physiology just to provide a little bit of context to some of the questions that we ask the patients, and then talk about the role that the medical assistant and the nurse plays in the management of our patients. It's just a vision and mission for U Chicago. Objectives. We're going to review the fundamentals of uterine fibroids, understand clinical evaluation and treatment options, and identify some key responsibilities in fibroid care. My disclosures. So what are fibroids? They're benign tumors of the uterine muscle. They're very common. Up to 70 to 80% of women will be affected by uterine fibroids by age 50. Important to note that not every woman with fibroids has symptoms. Sometimes it's incidentally seen when a woman might have an ultrasound for another reason, but they may not be symptomatic, meaning they may not have any idea that they have the fibroids. And in that case, there's not much to do except for surveillance. But when a woman does present for fibroids, usually she's having symptoms. They are not cancer. If a fibroid is a fibroid, then it's a fibroid. There are tumors that look like fibroids that could be cancer, but from what we understand, and for the purpose of this discussion, we think of fibroids are benign tumors. So, what are the symptoms? Most women with fibroids, if they're going to have symptoms, will have heavy menstrual bleeding, pelvic pressure or pain. Depending on the size of the fibroid, if they get really big, just like a pregnancy as it gets bigger, you might notice the patients may complain of urinary frequency. They may have some constipation. They may feel bloated, like their belly is getting larger. And in some cases, they may actually present with infertility and pregnancy complications. So I'll give you an example. Here's my arrow. This is a woman who has fibroids. As you can see, it's pretty large. Right here up here is her belly button. This woman might have some pressure symptoms. She also has a fibroid really low down where her rectum is. This is her spinal cord back here. So just to give you an idea of how some fibroids might cause a lot of pressure when they're large. Um, okay. So heavy menstrual bleeding or abnormal uterine bleeding. What's important here? Well, in order to know what's abnormal, we have to kind of know what normal is. So normal periods usually occur every 21 to 35 days. That means from the first day of one period to the first day of the next period, that's the cycle length. And it can be every 21 days, which is every 3 weeks, which is very frustrating for women because in a long month, like for example, January, they may have two periods and may be very frustrated, but that's actually would still be considered a normal length. And it can be up to 35 days. The menstrual length is usually anywhere between 5 to 7 days on average. Some women might have 3 days, and even within the 5 to 7, there may be some days of heavier bleeding, and that varies per person. And the average blood loss is about 80 mLs. I mean, we don't obviously measure our blood loss, but that's on average what it is. Typically, we think about abnormal bleeding as when a woman feels that her bleeding is heavier than it used to be, or if women describe things like having flooding, feeling like they have to wear two pads and a tampon. All of these things could be indications that the bleeding is abnormal and heavy. And this could be a sign of fibroids. Well, what else could it be a sign of? Well, it could be a sign of other things. There are other things that cause heavy bleeding. So when a woman comes into the clinic with abnormal bleeding, she may have fibroids, and depending on where the fibroids are located, it might not actually be the cause of her bleeding. She could have a polyp, she could have adenomyosis, leiomyoma, that's fibroids, or malignancy. So when women are older and they have heavy bleeding, we often will do a biopsy, or if they have, even if they have fibroids, we might do a biopsy just to rule out any type of cancer, precancer, because we don't want to assume it's the fibroid and miss something really bad. There are some non-structural things that can cause bleeding, coagulopathy. So some women might just not clot very well. They may have anovulation, so they're not ovulating monthly, and that could be because, say, they have a thyroid disorder or there's other things going on. It could be because they're on a medication, like a blood thinner, for example, and that can cause their bleeding to be very heavy, and a few other causes. So how do we diagnose fibroids? Typically, the first thing to do is a pelvic exam. Most commonly, it's diagnosed in ultrasound because the person is coming in because the ultrasound showed the fibroids. But if a woman has heavy bleeding and just comes to the clinic with complaints of that, you'll see we often are ordering pelvic ultrasounds. The other important thing is, sorry about that. The other important thing is when we're doing surgical planning or a woman has many fibroids, her uterus is very large, we typically would get an MRI. It helps us to understand a little bit more about what's happening within the uterus and also helps with surgical planning. Even women who might be getting a fibroid embolization, oftentimes we need an MRI because it helps us map the location of the fibroid and also the blood flow to the fibroid. Down here is another type of ultrasound called a saline ultrasound. Here we put some fluid inside the cavity of the uterus to open it up and see if a fibroid is inside the cavity of the uterus. And these are the types of fibroids that are often responsible for very heavy bleeding. Depending on the size and location of the fibroid, that helps to determine the type of treatment the patient might need. This picture up here is a hysteroscopy. So oftentimes you'll see us schedule patients for hysteroscopy. We're putting a camera through the cervix and we're opening up the cavity to see. So for example, if we see on ultrasound that part of the fibroid is in the cavity here, this is what we might see when we go to the operating room, and then we can kind of resect it. All right. So what is the role of our medical assistants? It's really important. We're very dependent on just accurate symptom bleeding documentation. A lot of times when women are coming in with bleeding, I think we tend to, just as women, we may minimize our symptoms. Some people over exaggerate their symptoms, but I think more commonly, women who've always had heavy bleeding might say, oh, well, my periods are kind of heavy, they're okay. But the more you talk to them and ask them questions, you'll realize that no, they're not okay. So a woman might say to me, oh, I think I'm fine, they're not too heavy. And then I say, well, how many times do you have to change your pad and how quickly? And they may say, oh, I change it every hour. And I'm like, well, that's not normal. But they may not know because they've just lived this way for so long. Sometimes women might say that, oh, their bleeding is completely normal, and then we'll check their blood count and they're anemic. And so just being able to accurately get those questions answered would be really helpful. Oftentimes, we'll ask them again to just help them think about the question even more by the time we come in for the visit. And then preparing patients for imaging and procedures. So obviously, we don't do any imaging in most of our daily clinics. If you're an ultrasound, for some reason, that's where most of it is done. There are some clinical settings where imaging might be done in the office, but in our practices, we don't have that. I know that some people do saline sonograms. And so for those of you who might work in that space where your provider is doing the imaging and the saline sonograms, just preparing the patients would be important. For procedures, we do a lot of those. So oftentimes we're doing biopsies, sometimes polypectomies, and these women who might have fibroids and polyps. So all of these procedures are sometimes done in clinic and really important that patients are prepared for it. I think we do a fantastic job of that. The consenting, making sure patients understand exactly. Sorry. I have an automatic reminder about the weather. I apologize for that. And then so preparing patients for imaging and procedures, and then coordinating referrals and follow-up. I think in many of our settings, the medical assistants, the role that you might play may vary depending on the setup of the clinic. But the follow-up and need for referrals, oftentimes that will fall on us as the physicians to put the orders in. But if at any point in time there's a miscommunication, a lack of understanding between what I've written down and what the PSRs in the front desk are seeing, that might be a space where you may come in. And oftentimes this is going to be indicated in the notes or in the discharge instructions or in the patient follow-up instructions where we say, consult placed, follow up in X number of weeks. And so just being kind of familiar with where that information is can help streamline any miscommunications or breaks in communication along the line from when the patient leaves the physician in clinic and is checking out. Updating vitals and medication lists is really important. So a lot of times patients don't remember what medications they're on. So if they haven't had an opportunity to either go over at least one time before they come in to see the provider, it may not jog them. They may not kind of be at the top of their mind what medications they're on. And this becomes really important because some of the behavior of the uterus when it comes to bleeding can be very much tied to the medications that patients are on. So if they're taking a blood thinner, they may even forget about it because maybe they've been on it for a long time and they don't realize that it is important to mention. And then another important thing for medications is when we think about patients' risks of surgery, knowing the medications they're on help us to think about what other conditions they have. So if they're diabetic, if they're hypertensive, if they're on insulin with diabetes, that's a little bit different than if they're not insulin dependent. So all of these what seems like maybe not huge deals can be very informative and help to close any gaps that may exist in the short 15 minutes that we have interacting with the patient. If we miss it, then we can know that when we're writing our notes, we'll see that. And I've caught that sometimes. Say I've had a visit with a patient, it's a consultation. So we've talked about all their symptoms, and somehow it kind of just didn't come up that they're on insulin or it didn't come up that they're on a GLP-1 like Ozempic or whatever. But then I look at their notes, I'm like, oh my gosh, this patient has, is on insulin. Let me make sure that I talk to the endocrinologist and make sure that they're all set for surgery. Or maybe I need to get blood work to check her sugar levels, her A1C. So having all that information in the chart is helpful. I think we do a great job with obtaining vitals and even a more excellent job with recognizing high blood pressure, when to ask patients to go to the emergency room. All of those things are critically important and help us to know that, okay, that's taken care of. I don't have to worry about it because I know that my MA is on top of it. When it comes to the role of nurses, and there's some overlap, I think it's just important to state that the role of the medical assistant and the nurse will change depending on where the practice is and the practice style. So I may talk about it within the scope of just my immediate practice, but this is not across the breadth. So there are some MAs and nurses who might work as part of the pelvic pain center and they do Botox and they do a bunch of different things. So I think it's important to keep that in mind. So patient education and treatment options. So oftentimes, as a nurse, I know all of the nurses know this. A patient may have a discussion with me, and I may spend minutes, hours talking about all the treatment options, and then they walk out, and maybe a week later they call and be like, I don't know, I don't really know what's going on. I don't remember what the treatment options are. So, just being aware of those things. Oftentimes they're in our notes or in our discharge information, what we want the patients to know. But I think and I think our nurses do an excellent job of reviewing options and just saying, oh, this is what your doctor's note said, or you actually have access to your doctor's note through your My Chart if they're signed up. Um, Preoperative and postoperative teaching. I know we established our preoperative clinic a few years ago and has been very successful. I think patients definitely feel like they're in the loop. Oftentimes, the time from scheduling a surgery to actually doing the surgery can be a few weeks, and things get lost, people forget. So I think that preoperative teaching and postoperative reassurance is so important for the patients to feel heard, right? And to feel like they're not alone, especially if they're having some challenges. So I think our nurses do an excellent job of that, but it's such a big part of the care that we are providing to our patients. Assessing for anemia, severe symptoms, of course, preoperatively, but even postoperatively, if patients seem to be having more symptoms than is expected after surgery. Those are definitely triggers. I think the nurses being able to identify, okay, this is not a normal pain. I wouldn't anticipate this number of weeks after surgery, right? This is unusual, and letting that trigger kind of the next step of what needs to happen. Emergency room, urgent care, come in for a visit. And then monitoring for complications. And I think, again, we do a great job with this. When patients call in, sometimes there's nothing going on, but they need a reassurance. Sometimes there is something going on. And I've had scenarios where my nurses have caught something or said, I really think they need this. I really think they need that. Sometimes, when you're the one picking up the phone and hearing the patient, it's very different than when I'm just getting a message. So sometimes there's something about your gut and think this seems weird. The patient seems more concerned. Maybe this requires a little bit more more attention. So, we're really relying a lot on your expertise and your experience. And even sometimes the relationship you've built with that patient can really be helpful for them to feel safe enough to tell you things that they may not tell us for different reasons. Red flags to recognize. I mean, I think if a patient comes in um, and is not quite looking right, or their pain just seems really more than expected, especially post-operatively, those are definitely red flags. Very heavy bleeding. These are patients who, you ask them the typical questions like, how much are you bleeding? Are you soaking up a pad in less than an hour? Are you feeling short of breath, lightheaded? When to go to the emergency room? When to think about transfusions or infusions and working with the team to know how to do that. I think we have a really great process of getting our patients in for iron infusions and things like that. And we really, really depend on all of you to help make sure that the patient gets all of those things taken care of, especially in preparation for a major surgery. Rapid abdominal growth, I put that there mostly because, I think I had mentioned very briefly that there are some tumors that look just like fibroids, but may not be fibroids. Now, although rapid growth doesn't mean it's not a fibroid, it definitely indicates that they may be a sooner need for intervention. So, I think at the University of Chicago, especially in the Hyde Park location, we see a lot of very, very large fibroids. I think a lot of women are either scared to go to the doctor or they delay their care. I think just really the importance of just having some empathy and remembering, like, no matter how crazy our day is, a woman who's taking the time to come because she's in distress is probably having a worse day than we are. I always have to remind myself of that, especially on challenging days, when you might just, feel exhausted and frustrated for many different things. But women with these very large tumors are often really, and many of them have been dismissed for a long time. And so they may come in with some angst and frustration that is thrown at you. But even for myself, I have to remind myself that it's not personal. This person is probably suffering, and really, really having a hard time with this pathology. Pregnancy complications. Now, although in my personal clinic, because I don't deal with obstetrics, I may not see this much, but definitely within the OBGYN teams, you'll have women who have large fibroids and a pregnancy. And these are women who need to be watched more carefully. They oftentimes have a stronger association between these large fibroids and very significant pain in pregnancy, sometimes requiring hospitalizations for long periods of time, sometimes leading to preterm labor and preterm delivery, loss of pregnancies. So even when these patients with large fibroids call with pregnancy complaints, it's even antennas up because anything that may have not been that much of a concern without that big fibroid ends up being something that should be paid more attention to with that big fibroid. So fibroids can definitely be a source of pregnancy complications. Not all the time, but they surely can be. Um, Supporting patients, I mentioned this earlier, being empathetic. I mean, I think historically, fibroids are so common, and the issue with that in some ways is that, and the fact that not everyone with fibroids has symptoms is that it can be easier than you might think to just like minimize a patient's symptom, especially because it's not a cancer. But the impact on quality of life is quite severe. I mean, I have, we have patients who are, normal hemoglobin is above 12 and they have a hemoglobin of 4 or 5. They feel exhausted. They think something is wrong with them, like mentally, but like, no, you don't have enough blood. They feel overwhelmed. Many of them have been dismissed, like a lot. I mean, I have women who are coming from Indiana, from Wisconsin, because they've been told, oh, it's just a fibroid. Don't worry, it'll go away when you're in menopause. That's not true. Fibroids don't go away in menopause. If they're already big, like the size of a watermelon, it's not going anywhere. It's still going to be the size of a watermelon after you go into menopause. But many women are told to do nothing, or they're told, even at young ages, that they should just have a hysterectomy. So I've had women who are coming to see us in our clinics, just really, really scared because, they're young, they don't have children. I just had this as soon as like last week, I had a patient like this, and she was told she had incidentally found to have a 10-centimeter fibroid. She's 24. And the first information she was given was she needed a hysterectomy. And then the next was that they could do a myomectomy, but it would be like a big open incision, and she would be out of commission for, I don't know, 8 weeks. Now she's a firefighter, and she's like, I can't do that. And so she finds her way to us, and it's going to be robotic. She'll go home the same day, right? So, but these women are usually coming with that burden and this fear. And so just being empathetic is really important, and reminding ourselves of this reality, I think, can help frame some of the anxiety that we might see in our patients. And then encouraging patients to ask questions. I think, sometimes because of time constraints, it's 15 minutes and we have to room this person, and oh, there's not enough room. It is so easy to kind of be in a rush. I even have to like remind myself to pace myself and not try to feel like I'm like rushing. So like I always say, is there any other question that you have? Or, I may not be able to answer your questions, but you can send a message and we can do another visit, maybe a virtual visit, but just making the patient feel safe, because I can guarantee you that many of the women who are coming to see us have never really felt very safe in a doctor's office. Um, Clarifying instructions after visits or procedures. So, we have these templates. We usually try as physicians to go over the details as carefully. And I think patients listen, but again, because they have so many things going on in their minds, there's a lot of information that could be missed. I oftentimes can think of it like when I go to the mechanic to get my car done, like they say a lot of words, and I'm like, yeah, I mean, yeah, sure, I think that makes sense, but if you were to ask me after I leave there what they're doing to my car, I'd be like, I have no idea. Like I'm just hoping for the best, you know? So even the most brilliant non-physicians, people who are not in the medical space, they don't remember some of these details. So I think being patient with them and say, okay, this is the instructions, this is what you should do. It's okay to have a little bit of pain, too much pain is not okay. And just kind of going through that and breaking things down for them from major surgeries and even after minor procedures, colposcopies, biopsies, all of those things that we do in clinic. It's a lot of anxiety for the patients, and just supporting them goes a long way. And then, sometimes we'll have patients who we have a plan, and they're supposed to see us back in clinic in 3 months, and let's see how the medication is working, or let's look at your ultrasound. And by the time they're coming back, they haven't done the ultrasound and they didn't even take the medication. So I mean, I think these are some of the things that like sometimes, again, depending on how the clinic flow is and who the touch point person is, like when a patient has a follow-up, it would be nice to have had a call saying, okay, you're coming for your follow-up visit. Have you had the ultrasound that Dr. X scheduled for you, or ordered for you? And those are some of the ways that we can make sure that their actual visits are worth their time. I had a patient today who this exact thing happened. We saw her a few months ago. We said, start this medication, get your ultrasound, come back, let's see how things are. And so she came back and she was like, oh, I forgot to get my medication. Oh gosh, I didn't do the ultrasound. So we're like, okay, take two. Let's try these things again, and then we'll see you back. So, some of the ways that we can probably avoid that is for the follow-up visits. Again, depending on how the clinic runs. In some of my clinics, I do have all my patients are called a few days before, and some of my offsite location, and they'll say, have you had all these things done? If not, please, just be aware that they may not be a complete visit today, or you may have to get those things done before you come. So again, those are some of the roles, again, depending on where you are, what your practice is like, and what your physicians do, that you might play to make the patient care complete. Okay, let's move on. So what are some diet and lifestyle modifications that can help with uterine fibroids? So this is, I would say, relatively new information, but not really. I mean, I think probably in the last 5+ years, there's been more and more data coming out about the role of diet and lifestyle in management of uterine fibroids. The important thing here to think about is that all of these lifestyle modifications affect many other health conditions, because each of these things try to decrease the inflammation within our body. And it's the inflammation within our body that has been found to be the central cause of many health outcomes. So what's probably novel about this in the last few years is that some of these has been linked directly to uterine fibroids more recently. So we've always kind of known that vitamin D deficiency increases fibroid growth. We've known about red meat and alcohol. These are all sources of a lot of inflammation within the body. What's newer is that we've tied this to a specific mutation that we've seen in fibroids. So we even have more proof that these modifications can actually help in women with fibroids. So you might see in some of my discharge information, for example, I'll have a section where I say, take vitamin D supplementation with, vitamin D should be taken with K2. I don't have that here. Green tea extract. These are things that decrease inflammation. Stay active, watch your diet, decrease red meat, decrease alcohol. And these are all modifications that actually do help to decrease the symptoms of uterine fibroids. And also in studies, we're seeing that it actually slows down the growth of fibroids over time. So other treatment options, watchful waiting. So for women who just incidentally found out they have fibroids, like I had a couple patients who, maybe went to the emergency room for feeling lightheaded or something, and they were diagnosed with something else, but they had an ultrasound because they had some abdominal pain, and like, oh, you have a 2 centimeter fibroid, right? Sometimes patients get really anxious and they come for a consult, and it's like, oh, you're fine. Your periods are normal. There's nothing to do. We just need to keep an eye on this. So typically, every year with their annual exam, they can get an ultrasound to just keep an eye on how the fibroid is progressing. Oftentimes, if they're having symptoms, we'll start with hormones. So birth control can help as a form of contraception, but it can also help with making periods more regular and not as heavy. And then you may have heard of the Myfembree or Yan or Orlistat. These are all medications that can be helpful for fibroids as well. Ibuprofen actually does help sometimes with pain and even bleeding. So we sometimes will start with ibuprofen and hormones. Now I usually start patients on vitamin D, green tea extract, and using NSAIDs, especially if their symptoms are mild. And then for those who really don't want to be on hormones, we do that. One of the medications I don't have on here is tranexamic acid. I might have it later on. It's a medication that just decreases the blood flow or the blood loss that is occurring during a period. So that's another favorite for patients who don't want to be on any hormonal therapy. And then for procedures, you have a embolization. So you guys might have seen some orders for interventional radiology, fibroid embolization. This is an example of they kind of find the blood flow in the groin and they kind of thread a kind of a radiologic device through the vessel and they plug the blood flow and that helps the fibroid to kind of decrease in size. And then we have ablations like Acessa, Sonata, where we basically the fibroid is like cooked, like almost like a radiofrequency ablation, and that makes it fibroids are usually like firm like a rubber ball, but when you ablate them, they become like marshmallow. So they're not as heavy anymore and they usually don't cause as many symptoms for women. These are some of the treatment options that women can try if they're trying to preserve their uterus, but they don't really want future pregnancy. Surgery. So a lot of times, depending on the practice, in my practice, most of my patients who are coming in because they've tried all these other things or their fibroids are very, very large and nothing else is working. They're ready for surgery. The two most common surgeries performed where we're actually taking things out of the body for fibroids, either myomectomy or a hysterectomy. Myomectomies can be done in different ways. So here, the myomectomy is done hysteroscopically. So that's for a fibroid that's inside the cavity of the uterus. You can just go with a camera in there and shave it down. And then you have the myomectomy can be done through an open incision. Sometimes the incision is up and down, from the belly button down. Or you can have a robotic assisted approach or laparoscopic myomectomy. So many of our patients who we see at the University of Chicago through our fibroid center program, because we've gained some popularity in the area, will come to us to try a robotic approach because they've been told maybe by everyone else that they need a big open incision because their fibroid is really large. And we do specialize in doing even big uteri or big fibroids through small incision surgery. So this is kind of what a myomectomy looks like. That in there is a fibroid. This around here is the uterus. So basically you cut into the uterus and you kind of pull the fibroid out and then you close it back with stitches. For hysterectomy, I think an important thing to know, just for you to be aware of, like a lot of women sometimes will not want a hysterectomy even though they really need one because they think that when the uterus comes out that they'll go into menopause. So usually we explain to them, and this diagram is supposed to help explain that we actually just take the uterus and sometimes the tube, but we keep the ovary. So the ovary is right here. We don't take the ovary during hysterectomy. So I usually tell patients, no, you still have your ovaries. You're not going to go into menopause, but the uterus is going to come out. And then here in this diagram where you see these black dots all around, this is a patient who's having a hysterectomy and oophorectomy. So oophorectomy is the surgery to remove ovaries. So that's really a big concern for a lot of women. And once they realize, oh, okay, my ovaries are going to stay, then they're usually like, okay, yeah, you can take the uterus out. I'm not going to have a period anymore. I'm happy. I'm not going to have menopausal symptoms, especially when they're not, too advanced in age. And so that's really helpful for those women who are, candidates for just a hysterectomy without removing the ovaries. So those are kind of the big I think, fundamentals, things to think about when you have patients coming in with fibroids. So I think in summary, I would say fibroids are common and they can significantly affect patients. The importance of empathy, allowing the patients to have the space to voice what's going on, being kind even when time constraints are present, and it's not easy, I know. Diagnosis and treatment will vary, and that's really based on symptoms and the patient's goals. So, for example, women who want to have future fertility, they have a different set of options for treatment than women who are done with fertility. The size of the fibroid, the location, these are all things that influence the symptoms and also help guide both the patient and the physician about what options are safest and best for the patient. And then the medical assistants and nurses in our team, you all play a significant and key role in the care of this patient. I mean, from the moment they walk through the front door and when they talk about the reviewer, their experience is not just their experience with the physician, it's about everything. They think about the person who first said hi to them, the person who took their blood pressure, all of those things, the person who talked to them after they left and they didn't remember anything the doctor said, It's all of those interactions that kind of like make the patients feel safe. And they're often looking, I had a patient today, she was asking me questions about her surgery, and I was getting a little bit frustrated because I was like, I'm pretty sure I went over the details of the surgery with you a billion times. And then at some point she kind of smiled and she was like, I'm just kind of like checking you out a little bit. I just want to make sure the vibe is right. And it's like, but it was funny. So I kind of laughed and I was like, I hope the vibe is right, but like, are we doing this or are we not? But I think that patients just really want to feel like, they're in a safe place, that their experience and what their lived experience, when they're home, soaking up through pads, can't get out of their room, feel like everything smells. They're just so annoyed, all of those things, that they're not alone and that there's light at the end of the tunnel and that they're not going to have to go through the journey alone, that they have a team of people who are rooting for them and will do whatever it takes to make sure that they get to their desired goals. So thank you for your time, and I'm happy to take any questions.
This phone, I'm gonna be another phone.
Mhm. I
It's
have a
so bootleg now. Bootleg? It keep like blacking out and stuff.
Oh, wait, you can hear me?
No, I can hear you. There was someone else talking, but I was saying that I actually have a question for you. And great presentation. You mentioned all of the different procedures that one can have, and I think probably the majority, I know all of the nurses and
Nurses.
probably the majority of the MAs get asked by patients. They're either calling in after the procedure to say, I'm having this, is it normal? Or even before the procedure, they want to know what to expect, and they may ask them those questions before they even ask us. So is there kind of a quick and dirty like run through of this is a hysteroscopy? Because you showed us the pictures, but what is a typical, recovery period for a hysteroscopy? How much time off? What should they expect? And the same for, say, a myomectomy versus hysterectomy versus fibroid embolization versus excessa?
Right. Yeah, that's a great question. I'll say in general, there's some general overarching time frames that I think most people use, but that can definitely vary depending on the patient. So for any surgeries or procedures where we're not making incisions through the abdominal wall. So for example, that hysteroscopy that I shared, where we're just kind of going through almost like we would do let me go back to that picture, almost like we'll do with like a pap smear, right? We're just going in, they're going to have their legs up, we're going to put a speculum in, and we're going to do what we're doing like here. I'm gonna have it. So those procedures usually, again, they're same day surgeries. Patients are under sometimes general anesthesia, sometimes just a sedation, depending. They can usually return to work within a week or so, especially if they don't do jobs that are really very, very strenuous. Like I very rarely will have a patient who within anywhere between 3 to 7 days is not more than ready to go back. Usually they need at least 24 to 48 hours just to recover from the anesthesia. They'll have cramping. Most of the time they don't have a narcotic because we haven't cut the abdominal wall, right? Everything is in this, no incision. We're just going through the vagina into the uterus. So hysteroscopy just basically means I'm putting a camera into your uterus. And those tend to be, we think of them as minor surgeries. Now, I usually try to be careful when I say minor because it's a big deal for the patient. I just want to say these are surgeries that are less complicated because we don't have any incisions through the belly. Okay, so anywhere between 7 days, usually max. Sometimes you might say 2 weeks, again, depending on the patient and the kind of work that they do. Usually the patients will come to see us back for a post-operative visit around that time period, a week plus or minus 2 weeks. And usually from then they're kind of discharged from the surgical care and they can return to routine care. When you have patients who have any type of incision through the abdominal wall, they need a little bit more time because their abdomen has to heal essentially. If it's a robotic surgery or laparoscopic, so small incisions, and the patient has undergone a myomectomy, if they have a job that is sedentary, so they're just kind of typing, they really can get back within 2 weeks. But I usually say 4 weeks is kind of a point where I'm like, okay, by 4 weeks, my patients, even if you have a job that requires more activity, they usually feel pretty good after the myomectomy to return to work. And again, there's some variation depending on the extent of surgery done, but that would be kind of average. When a patient has done an open surgery, even for a myomectomy, kind of depending on how big the incisions are, because this incision here is pretty big, but sometimes we'll do what's called like a mini laparotomy, which is about half the size of this. I've had some patients return to work in about 4 weeks still, even after a myomectomy, sometimes 4 to 6, depending. For the hysterectomy, again, not too different with regards to returning to work or a job that requires just like typing or you can working from home. The big difference with a hysterectomy, especially when we've taken out the cervix, is that they need to have something called pelvic rest. So oftentimes you'll see we'll do a cuff exam or we'll say nothing vaginally. That's a really important time because the top of the vagina, we've taken the cervix out. So in this picture, this is the vagina here and this black dot indicates what's out. So we take this whole thing out. So the vagina is still there, and there's an incision at the top here where the cervix needs to be. That needs to heal. And that takes between 6 to 8 weeks to completely heal. So during that time, we don't want them to bear down or to push. So we usually don't want them to be constipated. So that's why they'll be on DUCHUH, or they will be on some type of stool softener. We don't want them to soak in a tub because we don't want any type of water going up in the vagina, and we don't want them putting anything in the vagina. So no sex, no tampon. They should never douche. Douching is never okay, but they definitely should not douche after a surgery like a hysterectomy because we don't want any bacteria going up into that space and causing any type of infection. So that's a maximum of about 8 weeks, but anywhere between 6 to 8 weeks of pelvic rest. So that's the general overview for the most of the procedures that we perform in gynecology. For the other procedures like the Acessa, again, depending on how much is ablated, the Acessa also requires incisions through the abdomen, although very, very minimal, not the same as the robotic. So the recovery is more like more similar to like a minor laparoscopic procedure. So about 2 weeks usually. If it's a sonata, which is another ablation that is done very similar to the hysteroscopy, that again is anywhere between 7 to 10 days that they can return. Now, patients will still need Tylenol or ibuprofen as needed. And so we kind of reinforce that. With regards to the fibroid embolization procedures, they often say 2 weeks as well, they can return to work. Some people return sooner. Again, these are averages. I have a nurse who was like, oh, after a week, I was feeling great. And I had another patient who was like, who's a resident. I was like, oh, I was back to work in like 8 days. And so everyone is different, but these are the average amount of time that patients can take off after these procedures. Most of our patients do go home the same day or within 23 hours of the major surgery. So the ones that the big myomectomies and hysterectomies, but all the patients with hysteroscopy usually go home within a couple hours of the surgery. Hopefully that, I know that's a lot of information, but hopefully that
No,
answered that
it was
question.
great. What's a normal amount of bleeding after procedures?
Great question. So I usually tell patients, well, it depends on the procedure, right? I mean, so if it's a myomectomy or any procedure where the uterus is still there, right? They can have bleeding. And the volume of bleeding or when we get concerned is when it is typically, I'll say if it's heavier than your normal period, that's a problem. If it's concerning to the patients, if you're like changing a pad and you're having to wear like a period pad, we need to know about that, especially if it's not your period. So those are kind of the red flags. So if you're bleeding more than a normal period, you're soaking up a pad in less than an hour, and it's just continuing over 2 hours, 3 hours, you're feeling lightheaded, dizzy, those are red flags. So what you might expect is I might need a panty liner, or I might have one pad on for a few hours and then maybe have to change it. That is within the realm of normal with any procedure that has the uterus still in place. Okay. So very similar to even women who are just having no surgery. When they're bleeding that much, that's a problem, right? So any bleeding that is like, whoa, this is unusual. I shouldn't be changing my pad in less than 45 minutes. And I shouldn't be feeling lightheaded because I'm bleeding. I shouldn't have large clots the size of my fist coming out. Those are all signs that you need to call in or go into the nearest place for evaluation. Now, I always tell women if we've done a procedure on your uterus, there's a healing period. So, in addition to just the regular bleeding of the uterus, there's also healing, like postoperative healing. The uterus is kind of like getting used to the trauma it just experienced. So, I do ask them to have some grace, but there's some really key important signs that okay, something is going on here. If the pain is not responding to the medications we've given you and the bleeding continues to pick up, that's a concern. Another important thing I tell women is like if I sense, okay, well, the bleeding is there, but it's not too bad, I usually will just say, if you notice as the hours go by, it's improving, that's a good sign. If it's getting worse, not a good sign. So it's almost like this idea of giving them a goal or something that they can look for and say, okay, this seems to be going in the right direction. It's probably nothing to be concerned about. So that's for procedures where the uterus is still intact. When you've had a hysterectomy, we don't really expect there to be much bleeding beyond a little bit of maybe some discharge, a little bit of like brown, blood as it gets old, it turns brown, it can be light pink. We are okay with just minimal bleeding. I always explain like it's almost like how you might have an incision or a wound that oozes, right? You might have a little bit of drainage, it's fine. If there's any odor and it's like a pungent odor, that's not fine. If you notice that it was pink and then now it's red, oh, now I needed a panty liner, but now I need a pad. Oh gosh, I need two pads. Okay, that's not good either. So if you're noticing this continued worsening of a symptom, that's a sign that there's a need for intervention. If it's a one-time occurrence and it's improving, again, we can watch and wait. So I think I guess my point is I want you to think about the two bottom line. If there's a uterus there, you can bleed. Okay. When are we worried? If your bleeding is more than your heavy period, we need to figure out what's going on. Maybe it can be like, okay, come in for a visit. It may not be urgent because you're like, well, yeah, it's heavier than my normal period, but I'm actually okay. That's fine. We can watch and wait. But if the patient is panicking and is like, whoa, this is more than I'm used to, like it's coming out, I can't stop it. Those are signs where I say, well, go to the urgent care. Let's go to the emergency room. If it's associated with a lot of pain, again, a problem, right? We don't expect it to be so much pain, especially if they've taken ibuprofen, Tylenol, it's not better. That would be concerning. Um, and then if they don't have a uterus, that's where we're a lot less tolerant with bleeding, right? Because there should be no uterus, so there should be really no significant bleeding. You definitely should not be bleeding even like a period, right? Any bleeding that's even like a period when there's no uterus needs to be evaluated because that's not an expectation. Another last thing I'll say is in women who've had hysterectomy, so there's no uterus. One of the important things is as they increase their activity, right, and they're walking more, even with the uterus, they may notice more is coming down than when they're kind of laying down for a long period of time. So that's another thing I might say. Well, as you increase your activity, if you notice a little bit more discharge, don't be alarmed. If you're using a panty liner, that's fine. If you need to use more than a panty liner and or the blood is getting bright red and consistent, please let us know just so we can have you come in for an assessment to make sure nothing is going wrong. I always think one of the important things is I'd rather, if there's any complication, it is best to catch it before it happens to prevent it. But if you can't catch it then, and it's happening after that they are left the operating room, the earlier we identify it, the better the outcome. So I usually tell patients, if things don't seem right, please let us know sooner than later so we can talk you through it and let you know when we're worried and when we're not.
Does anybody else have any questions? It's your opportunity to ask the expert. I have one more question though, because they were preparing the rooms. When are we doing endometrial biopsies and who?
Yeah, so there is some variability there, but standardly, endometrial biopsies are done on women who are bleeding in the postmenopausal period. So if a woman on average is older than age 50, although it's not universal, but if she says, oh yeah, I stopped my periods a couple years ago and now I started to bleed, that's a biopsy. So until we rule it out, we think, okay, that's a cancer until I can prove it's not. So that's postmenopausal patients. If it's a woman who is just having normal periods, but they're getting heavier, over the age of 45, we will biopsy almost all the time. I mean, it's very rare that we don't biopsy. And if we're not biopsying, it's because we are planning to go to the operating room to take a sample when they're asleep. Okay. So over the age of 45, or if they're postmenopausal. Now, if they're younger than 45, so over 35, and they have any risk factors that can increase their risk of cancer. So obesity, diabetes, hypertension. Those are some of the times when, even though they're less than 45, we'll still biopsy the patient. So, I mean, oftentimes, I think most of us do a reasonable job of when we first see a woman. I mean, for me in my practice, a lot of times it's initially a consultation. And depending on timing, I might do a biopsy right then and there. Some patients are like not interested in that because they're not prepared. And so they'd rather do it on a different date. And so there's a plan for a biopsy. And usually in our note, we'll say, consider biopsy, recommend biopsy, and some indication to return for a uterine biopsy. Another important thing that again might vary from practice is some women will get medications prior to the biopsy to help with their pain. So I, for example, will treat my patients with ibuprofen and like a Tylenol 3. I tell them to take it in the waiting room or when they're coming in for their triage, just to kind of like calm them down. Usually I'll make sure they have someone who can drive them, drive them home from the procedure. And so again, everyone's practice may vary, but those are some of the things. And I'll remind them because sometimes they'll say, "Oh, or you can remind them." I guess sometimes they may not remember to take ibuprofen beforehand, and it usually can be helpful in some cases. But those are the times when endometrial biopsy is recommended for abnormal uterine bleeding. Now, when if a woman is coming in for fibroids, which is kind of what we're talking about specifically today, keep in mind they may not have heavy bleeding. They may just have bulk symptoms. Like I've had patients who just are like, I have a huge uterus. I didn't even know I had it. I went in because I thought I don't know, I had some indigestion. So bleeding is not always what patients with fibroids present with. So if a woman has fibroids and is not bleeding, you don't really have to do a biopsy. The biopsy is really for the woman who's having heavy and abnormal bleeding. Now, if a woman has a huge fibroid and there's a question about whether or not it could be another type of tumor, sometimes there's a space there to consider a biopsy even when she's not bleeding. But again, that can be variable depending on the provider.